Yeah, thank you so much, the chairman and the faculty in this room. Uh, my name is Kwa from Hue Central Hospital. Unfortunately, Professor Win cannot be here in person today, so I'm going to talk this topic today. This topic related to the drug coating balloon in the bifurcation PCI. And I just want to focus on some information about the slide very quick. So this is our cardiovascular center in Hue Central Hospital in the middle of Vietnam. The bifurcation still challenges because it's take around 20 or 25% of all the PCI cases. The main problem is that maybe after we put a stent in the main vessels, the side branch may be compromised. We want to concern about the coronary or side branch osteorestenosis, or the complexity of when we have to choose the two stent techniques. And after that, the clinical impact, for example, longer procedure time, more metal layers for the patient, or the thrombosis or the TLRs after leg lumen loss with the two stent techniques. So the scaffold only when necessary. This the slogan that everybody in this 2025 hear so much. So in this picture, you can see the diffuse disease come to us quite much. So the role of DCBs at this time is increasing so much. And the why we consider drug coating balloon, because it's no permanent metal scaffold. We can preserve vessel physiology and reduce the long-term complication. According to so many beautiful cases from Dr. Ramnit, you can see that this is maintains the carina geometry in the Dano 2 and the lowering side branch osteorestenosis and potential reduction in procedure time and the DAPT duration for selected patients. And the DCB-based strategy for bifurcation, we have so many type. We have a hybrid strategy with the DES from main branch, DCB for the side branch, most widely studied. Or we can use DCB only for side branch after the optimal lesions preparation, ideally for osteoside branch lesions, or we use DCB only for both branch, the main branch and the side branch in some diffuse lesion. And all of that, we have a practical principle. It's just the case, keep it simple with short scaffold. And but not add on the bifurcation lesion we choose for drug coating balloon. I think that the suitable for DCB inside branch is that we following the ECB recommendation that is reference lumen diameter is over 2.0 millimeter, or is supplied over 10% of the myocardium, or is is a length of the myocardium, especially in the Dino 1 or Dino 2. And after we have a good lesion preparation, we follow up the protocol residual under 30% of diameter, TIMI non-dissection flow, limited dissection, and so many information that are here. And we can see this is not a most correct step, but I think it's suitable for almost case. We can use wire, the good lesion preparation, and we are optimal Kitsen's balloon inflation, and then we DCB inflation after the main vessel of the stenting and the final part. Some idea, some expert share their information that maybe we can use DCB before we put the stent in the main vessels because of some reason. And the valuable of the IVERS on the OCT in this is quite very good, because the vessel preparation is the key predictor for DCB success. I think that the gentle and long inflation, and we use the scoring cutting balloon, NC balloon atherectomy is very important. And you can see that if we have a reference lumen diameter around 3.5 and the around under 30% of stenosis, it means that it's around 3.0. It means that you don't have to very big balloon for the reference lumen diameter around 3.5. You just use a NC 3.0 balloon with the high pressure around 3.0 or 3.2 is enough. So this is some evidence up to date to 2025. You can see so much trial and studies prove that the DCB for side branch show lower side branch restenosis, reduce metal use and favorable outcomes. And in TCT 2025, you can see the OCVC bifurcation study around from Osaka, around 300 patients undergoing initial PCI for bifurcation lesions, and they have a main vessel of the stent, the POT, and Kissen's balloon, and then use DCB. Another group, you just only Kissen balloon. And then you can see that the role of DCB after 1 year's follow-up is better than without the DCB. And another systemic review and meta-analysis show on the TCT 2025. You can see that compare with the DCB for the side branch and the stent with the side branch with 2 technique stent, we can see that the leg lumen loss after the follow-up, you can see that the leg lumen loss is better when compared with 2 stent techniques. So the preservation of the vascular anatomy or reduced need of prolonged dual antiepileptic therapy or no permanent metal implant of the side branch is quite good, promising study to have a good application for the near future. And we apply that in some special scenario for tight bifurcation angles, higher carina shape risk for hybrid DES for main branch and DCB or side branch, for long and calcified side branch osteal lesion, or ACS involving bifurcation. So you can see that it is an ACS with the OM with the narrow angle bifurcation here. You can see good preparant lesion with the NC and cutting, and then DCB, and then this is quite good with no geometry problem in the bifurcation. Or you can use in the bifurcation lesion with a high latent respiration. With IVERS, you can see that this is very severe stenosis for high calcification and osteum LD, and stenosis, moderate stenosis on the osteum of the L6. And we use the crossover LM LAD with the gel balloon with the L6. And after the main branch stent, you can see that the side branch of L6 is compromised from the view of L6, from the view of the LAD. After that, you Kissen open the hole with the bigger balloon with NC 2.75 around low pressures with 15 to 20 seconds. And then you DCB. And this case, I have a chance to share the information in the My Life 2025. When the wide ballooning with the DCB, we performed Kissen balloon inflation at the bifurcation at the second, 55th, and 62nd, and then we deflated all together. It has to make sure that the bifurcation angle is good enough expansion. And after that, we check the IVERS again. I have a good, nice picture. And the pitfalls and how to avoid in the DCB intervention is that the poor lesion preparation will give us DCB failure. So we must have some tools like scoring, cutting, atherectomy when required. So the section after preparation, so we need to suitable stent. Using DCB is severe calcified or very small side branch will give us a suboptimal result and consider DES. And sometimes you have to wait to see what's going on after some minutes to do we need to bail off the stent for the lesion or after have a type T dissection with known flow limit in dissection. Some research is ongoing with the sirolimus drug coating balloon or pelletic cells. And conclusion, DCB offers simplicity by reducing metal burden and preserving vessel carina anatomy. Successful outcome depends on optimal lesion preparation and appropriate side branch selection. Hybrid DES and DCB is practical and effective in 2025 strategy for bifurcation lesion. Thank you so much for your attention.
Thank you, Dr. Hua. I think you can persuade me now that I should move all of my bifurcations PCI to DCB, especially for the side branch. Okay, it's good.